I use she, her pronouns. I am an assistant professor in the Department of Family and Community Medicine at the University of California, San Francisco. And we are presenting on the third component of person-centered contraceptive care training. I'm joined by Dr. Christine Dellendorf, who's a professor in the same department I work in and has really done a lot of work in thinking around person-centered contraceptive care. So if you had joined us for the first two sessions, welcome back. If this is your first session, it'll be more of a technical conversation about self-identified need for contraception, or SINC. Christine, if you can go ahead and share your slide.
Yes.
Well, actually, I'm sorry. One second before you do that.
Okay.
I will do the polls very quickly, and then I will pass it to Christine to give us a little bit of a recap and talk about this metric, self-identified need for contraception. So if folks are able, if you can, I'm going to copy a link. If you can join the poll here and complete these three questions, I will share my screen as well. If you have your phone available, you can also scan your QR code or go to the link I put in the chat, pollev.com/Rachel Logan 685. Okay, I see some people are already starting. So I'll let you look so I don't have to go through them just yet. We have a few folks here on the chat. Let me make sure. And yes, thank you, Christine, for putting that in the chat. If folks can, after completing the poll, if you can put your name and position and role in the chat, that would help us in our conversation today about implementing SINC into the clinic setting. So we have a few more surveys underway. I'll give it a few more seconds. Let me stop sharing, but I will track. So just three quick questions. And then we will return to these questions at the end to see if people's thoughts or attitudes or beliefs around these things have changed. So I'll give it about 1 more minute. I'm not sure if someone else just joined. I'll drop the link back in the chat. Thank you, Tanner, for introducing yourself, and you as well, Danielle. I know we have a number of things going on. So we have the polls, we have the introductions. I'll also put those instructions back in the chat. I have just a few more seconds to complete the poll. Okay. So thank you for those who completed the poll. Looks like 2 are still underway. So I don't know if folks still need to go ahead and hit submit on those, but thank you. And we will review the responses following this. So Christine, I turn it over to you.
Great. Thanks so much. I know it's relatively late for you all on a Friday, so appreciate you probably multitasking and eating lunch at the same time. So excited to be here. So we're going to be honing in today as the third part of the person-centered contraceptive care training on the idea of how we ask people what services they want and if they want pregnancy prevention or contraception. And that's my understanding is this is a little bit kind of the genesis of this whole project was thinking about the potential approaches to doing this and what made the most sense. And that was part of a broader conversation in the country about what makes the most sense to how to ask and screen people. So I'm glad to be getting to this part. I know we're a small group, but I'm hoping that people, no pressure, but can be interactive and kind of let us know what you're thinking, because this is really about kind of meeting your needs and figuring out what information you need to think about changes in practice. So I'm going to first do a quick review for those of you who were at the other two sessions, or for those of you who weren't, about what we've covered in the training so far. We really started with grounding the principles of person-centeredness, reproductive autonomy, and reproductive and sexual health equity as the real focus of why we provide reproductive health care, and specifically contraceptive care. And in that, we defined person or patient-centered care as care that is respectful of and responsive to individual patient preferences, needs, and values. So in other words, is paying attention to what people want, not what we think they should want, or assumptions about what they want. That it's about centering people in the context of their lives, and that this is a core dimension of quality per the Institute of Medicine. And it's also associated with improved clinical outcomes, that when we meet people where they're at and where they want to be, they are healthier. And that's an important thing that we all want as well. And it's really the idea of person or patient-centeredness is that we are trusting patients and communities about what's best for them. And again, not imposing expectations or judgments upon them. And then reproductive autonomy is another core principle, which is the human right to have the power to decide about and control matters associated with contraceptive use, pregnancy, and childbearing, so that people can make their own decisions. And it's obviously aligned with person-centeredness, because person-centeredness is about recognizing people's own desires and not centering ourselves or our systems about people in terms of how people make decisions about pregnancy and reproduction. So as we talked about in the first session, in person, reproductive autonomy does not have an age limit. We really need, when we're providing services to youth, it's very hard sometimes to put aside our expectations and judgments and biases about what people should be doing, particularly when they're younger, with respect to sexuality, with respect to pregnancy prevention and childbearing. But it's really important that we are honoring and respecting youth and teens and adolescents' reproductive autonomy, because if we don't, then that is going to damage the relationship in the long term with the healthcare system. So really important in the context of contraceptive care, it's very important. We think of contraception methods as something that give people reproductive autonomy, give people the ability to make decisions about their reproduction, and that's true, but it can also, and has in the past, impinge on reproductive autonomy depending on how contraceptive care is provided. And if people's own bodily autonomy is respected or not, makes the difference in whether or not contraception is in fact contraceptive care is supportive of reproductive autonomy or not. So we have to really watch, and like I said, make sure that we pay attention to if we have opinions or judgments about people's reproduction that then can manifest in the care that we provide in problematic ways. And that can be based on age, substance use, any number of things that we think means somebody should do something about reproduction. And we need to check that at the door and recognize that our job is to support people, to give them information, to let them know about what impacts some of their, for example, their diabetes, and whether their diabetes is controlled, could have on reproduction, but not decide for them what to do with that information or what they should do with that information. And one of the slides that I really like to use to talk about this is just make the point that contraception is not the silver bullet. I mean, when I got into this field, there's a lot of things we're gonna, if we just can get that patient on contraception, then X will happen, and that's the solution to that person's problem. So it's really important to recognize that issues in people's lives, including relationship status, socioeconomic circumstances, educational struggles, aren't going to be solved with contraception. And that our goal is not to solve people's problems with contraception, but to meet them where they're at and support them in their decision-making and their reproduction. And acting on judgments about who, quote unquote, I keep saying that, should prevent pregnancy interferes with reproductive autonomy, and in fact can reproduce inequities, because stratified reproduction is about making decisions based on whose childbearing is desirable and whose is not. And we can manifest that and reproduce that in the context of contraception care if we make judgments about whose reproduction we think should be controlled with contraception. So the goal should be to establish a trusting relationship with healthcare providers so that individuals can get the care they need. And particularly with teens, I just want to double make the point that being directive with teens has the potential to really damage a lifetime of relationship with the healthcare system and getting the care that they need. So it's because they're by eliciting reactants. So it's all the more important. It's more the more challenging sometimes because we tend to have assumptions and feelings about teens' behaviors. But we have to really recognize that we need to meet them when they're at in order to be able to honor their reproductive autonomy. Okay, and then we talked about shared decision making as an approach to doing this type of care, which is a collaborative process that allows patients and providers to make healthcare decisions together, taking into account the best scientific evidence available as well as the patient's values and preferences. This process provides patients with the support they need to make the best individualized care decision. So again, the process is shared. The final decision is up to the patient, and our role is to, when we're providing counseling, is to support people, make sure they have information, to support people in their context of their developmental stage for youth, right? So they may need more concrete information when they're younger and have a more difficult time abstracting because of the development of their frontal cortex. But that doesn't mean we're providing information in a way that is developmentally appropriate, and supporting them, but we are not making decisions and judgments about what they do with that information. Okay, so that is a brief overview of everything. Rachel, would you have anything before we move into talking about screening? Is there anything you would add?
I think you did a really good recap and just overemphasizing that young people are deserving of opportunities to exercise reproductive agency and autonomy is really key. And that oftentimes we really do struggle with that, even in public health, not just clinical medicine. And so it is a conscientious, ongoing process to ask yourself, is this something that I'm imposing or desiring for this person? Or is this something that they are saying that they need and want? And am I being responsive to that? So thank you for that recap.
Thanks, Rachel. Okay, so now we're going to talk. That was person-centered counseling, kind of principles. Person-centered counseling is what we've touched on so far. Now we're going to talk about person-centered screening for need for contraceptive services, and particularly talk about a tool that we mentioned in the in-person session, the self-identified need for contraception. So why do we think why are we even talking about screening in the first place, right? Well, the reason is because we want to meet people's needs, right? And optimize their health and well-being in the context of sexual and reproductive health care, right? And in order to do that, we need to know what services they want, right? So people often come in very clearly saying, I want STI testing, I had an exposure, or I have symptoms, I want X, Y, and Z. I want to manage my periods, whatever it might be. And so we very much absolutely need to explicitly prioritize the things that people come in asking for. But sometimes there are things that are implicit, or people might not even have thought. They don't know a clinic provides contraception, right? Or it might be that they feel that they are embarrassed to talk about it, right? So we need to make sure that people know that there is a door open to talking about contraception if they might be interested, right? Because there are barriers, embarrassment, stigma, judgment, particularly for youth around talking about it, right? And there's also lack of knowledge, right? There are people who don't know that there are a range of methods out there. So by opening the door by screening, you are helping to make sure that people have the broad range of SRH services available to them. However, the screening comes with risks, right? So we know sexual and reproductive health is incredibly personal and sensitive. There is a lot of stigma. People have experienced a lot of judgment, right? People get embarrassed. So we have to be really intentional about, if we're going to do standardized screening, doing it in a way that prioritizes patient comfort and doesn't communicate judgment about people's reproductive behaviors and decisions, right? Because if we do it in some ways, people can feel targeted, stigmatized. Well, this person is telling me I should be using contraception. They think I'm sexually active, whatever it might be. And that again can interfere with future care seeking and ability to have whatever their needs met are right now, right? For example, period management. And we also know that when people feel pressured in that way, in fact, they're more likely to not find a method that works for them in the long term, and therefore to not have their pregnancy prevention needs met when they want them. And I really like this quote. It's from a paper written by my colleague Anu Gomez when she was a qualitative study talking about people's contraceptive journeys. And this quote was from Jackie, a 21-year-old single mother who said, it's like every doctor's appointment they would bring it up. So I was just like, just give me something because you're annoying me. Once after Jackie sought emergency contraception, her providers also gave her unsolicited oral contraceptives. They were like, here, just take the pills. Jackie only took one pill, citing a desire to end the conversation with her provider as the sole reason she accepted the method. Although Jackie was actually interested in obtaining contraception, these repeated provider-initiated inquiries dissuaded her. So that is obviously a cautionary tale, right? We want to make sure we're opening the door, but we're doing it in a way that doesn't make patients want to run the other direction. So how do we do that? Well, the approaches that are out there are generally in two different buckets. One is a pregnancy intention approach, or one key question, which asks patients if they want to get pregnant within a year, and then triangulates based on that whether they should use contraception. If they don't want to get pregnant within a year, then they should desire contraception. The other approach is what we call a service needs approach, but asking patients what they would like today. And we already went over this in some detail in the in-person, but to remind you, and for those who weren't there, pregnancy intention screening, we feel, is very much not the person-centered approach that focuses on autonomy. So one reason from a person-centered perspective is that the planning paradigm doesn't resonate for many patients, right? Some patients don't have an answer to that question, right? That's not what they're thinking about is the year. They don't even know maybe where they're going to be living in a year, right? They know what they want right now, but they don't necessarily know what they want in a year. And so it's not person-centered or patient-centered to kind of force people into that paradigm, particularly for teens. There's also studies that have asked people explicitly how they want to be asked about their reproductive needs. And, shock of all shock, how people want to be asked about their reproductive health needs is to be asked what reproductive health needs they want to have addressed, right? They don't want to be asked about intention, right? So it's not person-centered to ask people about intention when we know that that's not what patients want to be asked. And it's also not ideal because it's not actually identifying it's not the best way to identify what services people actually do need, because someone may want to get pregnant in a year and want contraception now, right? And somebody may not want to get pregnant in a year and not want contraception right now. So we did a study actually looking at this, comparing pregnancy intention and desire to prevent pregnancy now. And as you can see, people who want to become pregnant in a year, 30% of them want to prevent pregnant now. And then you can also see on the ambivalent about being pregnant in a year, 54% want to prevent pregnancy now. So when we triangulate based on what people say they want in a year, we are actually missing people who would like to talk about contraception today. So therefore, it's not patient-centered and it's not ideally meeting people's needs. So we really argue for a service needs approach to assess doing contraceptive needs screening, as opposed to a pregnancy intention approach. And the reason the most important thing about this is, in addition to failing to meet people's needs today, doing it from a pregnancy intention approach for screening question, for all the reasons that I said about it not being person-centered, can actually contribute to negative care experiences, and therefore people may be less likely to come back and see us in the future. So it's really important that we do this type of screening in a way that centers people's own desire for how they receive care and have their needs identified. Okay, so that is why our team at the Person-Centered Reproductive Health Program created the SINC question, the self-identified need for contraception. So instead of it being based on what you told me about your pregnancy intention, I think you should use contraception or not, we really were intentionally saying this is about self-identified need for contraception, not about what other people think you should do. And the question is, do you want to talk about contraception or pregnancy prevention during your visit today? I'm going to go into some detail about kind of how we chose each piece of this question. But this is embedded in a broader kind of implementation guidance. So starting with, we ask everyone about their reproductive health needs. Do you want to talk about contraception or pregnancy prevention today during your visit today? And then if yes, then and this is asked often by a medical assistant or a health educator. We'll talk more about that. Then it needs to be handed off to whoever provides the counseling. And if no, saying there are a lot of reasons why a person wouldn't want to talk about this, and you don't have to share anything you don't want to. Do any of these apply to you? I'm here for something else. The question does not apply to me. I prefer not to answer. I'm already using contraception. I'm unsure, acknowledging some people are just unsure, but they don't want to talk about it. And I'm hoping to become pregnant in the near future. Again, not asking about the next year, in the near future, whatever that means to people, that's influencing their lack of desire to use contraception. Okay. So just to let you know, I mentioned this again, and I think we might have sent this around, but if not, we can send this around to your to the network. But this is a paper we wrote about the SINC question that was published in Contraception last year. And what you'll notice here is that it was a collaboration of coming up with this question between myself and some other academics, Lisa Caligaris at University of Washington, Sonia Barreros at Pittsburgh, and then Joya Kerr-Perry, Liza Fuentes, and Jamila Parrott, who are reproductive justice and equity leaders. And Joya and Jamila specifically helped us were in workshopping with us on a regular basis, coming up with this question initially. So just to go into some specifics, like I said, what are some specifics of what we really like when we parse this question? It seems very simple, but we were really aware of the need to make sure, again, that we didn't reproduce harm with this question. So we ask everyone about their reproductive health needs. That was something that came up out of our conversations with Jamila, Dr. Kerr-Perry, and Dr. Parrott about making sure that we frame this in a way that decreases people's potential sense of being targeted, right? That I'm not asking you because you're using substance. I'm not asking you because you're coming in with chlamydia. We're doing this because we ask everyone. And of course, that actually has to be true, but making that very clear. And then contraception or pregnancy prevention. We had a lot of conversations about this. And we intentionally didn't use birth control because I'm someone who uses the term birth control. I think that is a language that many people understand. But in the concern in terms of standardized screening was that it is a potentially triggering phrase with respect to reproductive oppression and coercion. So while people may use the term birth control, being asked specifically about control in the context of standardized screening was not seen as desirable. So we wanted to use contraception. And we knew that not everyone understands the term contraception, right? Because it's a complicated word. So therefore, we did this double-barreled contraception or pregnancy prevention. So there was a lot of thought and intention that went into that framing. Okay, and then if no, the clarification prompt. Again, not saying like, why not? Why not? Is it because you're already using something or do you want to get pregnant? Right? There's a lot of potential to layer on stigma and judgment if someone says no, they don't want to talk about contraception. So instead of that, we built out this guidance for how to respond to it, and this is not set in stone. It's not like people have to say this word for word. And we want to make sure that the principles of why we wrote this guidance out the way that we did are maintained, right? That it's so important not to reproduce stigma and judgment with how you respond when people say no to SINC. And so really making it clear that people don't have to share anything they don't want to. They don't have to justify not wanting to talk about contraception, but it's helpful to have some idea about why, because it helps us provide care for them, right? So if it's because they're here I'll go into more details, but those questions, the answers can help us to figure out how frequently to ask them and if they need refills or if they want support for a healthy pregnancy, all those kind of things. And then the answer options were also very intentional, including being intentionally ordered so that the first answers were not already using contraception, which is, again, being like, is it because you're already using something? That is in there, but it's not the first answer options that we list for the purpose of making clear that that's not the only acceptable reason for not wanting to talk about contraception. So how does this question integrate it into clinic flow? So it's designed as a screening question, obviously, we're talking about screening. So therefore, a standardized approach that everyone gets at least yearly, right? So that's the idea, is that everyone's asked at least yearly. But it depends on the context. In some places, it might be something you want to ask quarterly. In some places, it might be something you want to ask every day. It depends, or every visit. But you have to be very thoughtful if you do that about making sure that it's not that does not communicate like to Jackie, like it did, that we are not honoring reproductive autonomy and the right to say no. So we usually recommend that it's asked by medical assistants or health educators, not by the licensed clinical provider, because of again, the potential to communicate expectation that people use contraception and the hierarchy that is stronger with in the room with the licensed clinical provider. It can also be used in pre-intake questionnaires, right? So either like on a tablet or on paper or something like that, which even provides more space for the patient to feel comfortable with answering the question. We do recognize and have heard from people working with youth specifically that sometimes it makes the most sense for it to be the provider, particularly in primary care clinics, because oftentimes the screening is happening with the parent in the room, and whereas the one-on-one time with the adolescent, with the parent out of the room might be a better time to ask that question. So in that context, it might be something that's better to be asked as a standardized provider clinician's assessment. But obviously, like I said, you have to be very clear about how you ask it in a way that doesn't communicate expectation for the right answer. So we see it most often integrated into the rooming tab in the EHR where other questions are asked as well. So in practice, like I said, I'd come back to these no responses. What do you do if someone says no, and what different responses does that trigger? So these are some suggestions. So I'm here for something else. The one thing you could always say is, okay, that's fine. If you're interested in talking about the future, let us know and we can schedule an appointment, right? Or you can make sure that the next time they come in, it's asked again, just to make sure that they have their needs met. The question does not apply to me. You might want to see if you can respectfully, figure out why they might say that, or if they don't want to be asked in the future. Maybe they don't have sex with someone who has sperm, right? And so that's something to consider in terms of making sure that they don't feel like you're asking them inappropriately moving forward. They say, I'm already using contraception. That's a great opportunity, if we don't know that, to document it in the medical record, right? We see that people get contraception elsewhere and then we don't know what it is. And then we maybe prescribe medications that are problematic, or some other thing. So that's a real great opportunity to just document people's health history. And then someone who says unsure, doesn't want to use a contraception, that our goal is not to fix that in the moment and say, like, well, then I'll give you prenatal vitamins if you're unsure or something like that, right? It's to recognize that people are unsure about some things, and that's our job is to support them to the extent they want to be supported. And so again, you can ask them, well, do you want to be asked in the future? Do you want to talk to anybody, or do you not want to be asked this question in the future? That's an opportunity to engage with them about what makes the most sense for them. And then, of course, if someone said they were hoping to become pregnant in the near future, you can ask them if they are interested in talking to a provider about healthy pregnancies and fertility. So I'm going to hand it off to Rachel, I think, right, Rachel, for this next part?
Yes. Thank you so much, Christine. Before we get into some of these different cases, I want to pause for a second and see if folks have any questions about the content or information that was just shared. And also feel free to put it in the chat if you do. You can come off of mute if you don't mind asking your question verbally. Okay. Hearing none, there will be other opportunities for folks to ask questions or share comments. I will just share briefly that the Person-Centered Reproductive Health Program had a learning collaborative with federally qualified health centers, had 9 sites participate. Initially, there were 10, but 9 sites that decided to implement SINC into their clinic workflows. And they did a combination of submitting EHR data around how many people were screened and what those responses were. So calculating the percentage of people screened and tracking that over time. And then folks at the exit or end of their time implementing SINC, they were given an exit interview by one of our staff members, and some of the quotes that we'll share uplift some of that. So even though these are primary care setting examples, clinicians had this process of identifying needs in their clinic and then determining how SINC might meet some of those needs in a person-centered manner. Next slide, please. So the first quote here is really from a provider who, in wanting to implement SINC, had to work with their team at their site initially because how people were offering contraception or contraceptive education, there was no rhyme or reason to it. It was haphazard. Some people were asked about contraception, other people were not. And so this particular clinician really appreciated that SINC offered a standardized way to meet clients' needs, to do documentation that was pretty consistent. So what they communicate here is that, this is something that we can talk about. Again, this is a primary care setting. They're addressing a lot of different needs. And so what SINC helped them communicate to patients is that contraceptive care is important. It's just like the other services that we offer here for you, and that this is for your overall health. And so that was a value that the clinician really appreciated SINC helping them with. And then again, standardizing care, not only for individual patients, but collectively, making sure we're meeting the needs of patients consistently. Next quote, please. And for this quote, the provider really acknowledged that SINC helped with prenatal care in this case. So as Christine kind of mentioned earlier, sometimes the way that we ask the question already is laden with judgment around what we as clinicians, health educators, other providers think people should be doing. So in the context of prenatal care visits at this site, the person essentially around, let's say, the second trimester, even as the person is getting ready for their delivery or birth, are saying, what do you plan to use? And there's this underlying assumption with that statement that someone needs to be using contraception soon after they give birth, or, there's like some latent judgment in there. So for them, instituting and implementing SINC at their site helped to open up the conversation, and it felt a bit more welcoming. So they talk about how SINC was able to help them do that and how it kind of shifted the care dynamic between them and their clients. Next slide, please. And additionally, clinicians also talked about how siloed care is. Again, this is a primary care setting. So we have at federally qualified health centers, different departments, different parts of the site that someone can access care in. And unfortunately, a number of the primary care providers didn't talk about contraception with patients pretty much at all. And so people would, once finding out that their client, their patient wanted contraception during their visit, they would call over to the Women's Health Center and then try to get a patient in during that slot or their already existing visit to see a clinician. That sometimes worked, and of course, sometimes it didn't, because the Women's Health Center already had patients that were scheduled. So what it created was a delay in care. And of course, this is not very person-centered, that people have such siloed care, even when essentially FQHCs are supposed to be kind of like a one-stop shop. So what SINC helped this site do was implemented in a way where, early in the visit, it's now understood and known that the person wants to talk about contraception, and they're able to slot a patient into an opening and then meet that need. And so again, a standardized way to do it so that we are not making judgments about it, but a fairly streamlined process to ensure that we're meeting patients' needs. So clinics have different structures. Thank you for those who introduced themselves and put where they work in the chat. So what we're going to do now in this next phase is really talk through what it could look like at your site, at your organization, to implement SINC, and to do a bit of a process map to help folks. I have a worksheet available. We won't be able to go very deep with it today, but we'll share it for other sites and teams to work together to figure out how SINC might be implemented best at their site. And Christine, I will pass it back to you.
Great. So, yeah, if people could just, this is a good moment to just take we're gonna, I mean, we ideally want this next part to be interactive. So I want to kind of ask people to put something in the chat or some indication that they're listening and able to interact so we can have some conversation about what it would look like to have SINC implemented in different contexts. Are people out there? It's hard to know when there's no video on. Okay, we go. Alexia, thank you. Anybody else? Thumbs up?
Yeah, if you think your site might actually implement sync, feel free to put implement in the chat.
Thanks, Amy. Okay, well, we'll keep going, and hopefully I will just give you some context, and if there are people hopefully can give us some perspectives on what they're thinking. And Lisa, thank you, listening and thinking about how it's going to be applied to other things we do at our clinic. Great, yeah, absolutely. I would just add, yeah, that's SINC and the SINC approach of screening in terms of asking about other needs as well, including PrEP, for example, can be something that can be very much generalized. That's the one. Great. Yeah, and finding ways. I mean, we definitely talk a lot about the ways in which thinking about HIV prevention and offering it has a lot of the same benefits and pitfalls that contraceptive counseling can, right? You don't want to communicate stigma, you don't want to communicate judgment, and you don't want to communicate expectations about the right choice, because there are a number of different choices that work differently for different people in different points in their lives. Luckily, we have that for pregnancy prevention. We also increasingly have that for HIV prevention. So thinking about this thinking HIV prevention from a very patient-centered perspective as well. All right, so some things to think about implementing SINC and or other approaches to screening for other reproductive health needs. Changing things in a clinic can be hard, right? So what are the things you have to think about in a clinic setting to implement SINC specifically? Well, one is just implementing it into an electronic health record or whatever system you have, if you have a system for recording information, right? And that can look different. We'll talk a little bit about that. How it can be then implemented in clinical workflow, right? Because obviously once you put it into something, into the medical record, that's one thing, but then what does it actually, does it just sit there? How is it actually used? And then once you have the idea for what the clinical workflow could be to implement SINC, how can you make sure that it actually happens, right? There's a lot of best practices for various things that actually never actually come to fruition and get executed and don't stick, or maybe get executed for the short term, but then aren't sustainable. So these are the things that we really encourage you to think about in terms of approaches. So for the first one, how can it be implemented into electronic health record or health record more broadly? So things to think about when you're considering this is, where does it go? What module, component, what part of the electronic health record, right? So for example, I mentioned the rooming tab. That's an Epic. There's a rooming tab, and that's what we use. And that's where SINC is in Planned Parenthood and in various FQs around the country, right? But it depends on your context, whether if there is anything akin to a rooming tab at all, or what it looks like, right? And the rooming tab sometimes not ideal because it doesn't necessarily get communicated to the provider. So there's that issue too. So you really have to think about what makes the most sense for that. You have to think about how frequently it shows up. Like I said, like, is it something that's triggered once a year as a care gap? Or is it something that's triggered at every visit, and then the whoever it is has to look back and see if it's been asked recently. One thing I do want to say is that we do not, I didn't say this explicitly, we do not recommend not asking SINC if someone's already using contraception, right? It should be asked of everybody regardless, because we want it, because again, discontinuation, changing methods is a normal thing, and people might be unhappy with their method. So we can't assume their needs are met based on the fact that they're using something. So just to be very explicit about that. So you want to think about how you're going to, how frequently it's going to pop up. And then there's also ways to customize repeats, right? Is it when someone says they're here for something else, can you click a button, depending on how flexible your EHR is, that then automatically makes it come up as a care gap at the next visit? And then how the responses are displayed for others, right? Is how we're making sure that it's something that once you're asked, it doesn't just fall down into some deep hole in the medical record that then gets documented that it was asked, but nobody actually does anything with it. So that's a really other important consideration. Does anyone have anything they can share about what it might look like in your setting to implement it in the electronic health record or into the medical record system?
So I've got a question about, because we see two different kinds of patients down here at the YYC, some that are coming for provider appointments and the others are just coming for testing and don't see a provider but see our tester. And we have implemented screening. It's almost like an expert kind of thing with the screening that we do. It's an online, it's an iPad thing. And they get screened for certain things. And then they also do get, and this is through Danielle. So shout out to Danielle through her CBS Foundation grant that allows us to do this screening and have navigators and stuff. Um, have you looked at doing this with like an iPad and asking the questions and sort of doing that? Because especially for the testing patients that it would be appropriate to ask about contraception for, might be an easy way to then shuttle those patients to an appointment for contraception.
Absolutely. I love it. And like I said, doing some kind of tablet or even paper, but you have a tablet, so it's great. It's nice because it even adds that extra layer of kind of lack of judgment and lack of like communicating that people and it's also embedded in other questions, so that's great. It's just like we're asking the things about your needs, right? And we want to meet them. I think that's a great way to do it. And absolutely, I think if people come in and you can get those needs met, if they're coming for a testing appointment and they indicate they want to talk about contraception and you can talk about that day, that's great. But it's also okay if that's like not, if the system isn't it doesn't necessarily allow same day appointments every time. You've made a huge advance by identifying that, because if you didn't ask them, then they'd leave and you wouldn't even know that they're interested in contraception, right? So scheduling them to come back for a visit is absolutely makes a lot of sense. So I really like that approach. Thanks, Lisa. Anyone else have any thoughts about ways?
I know someone else was from USF Health. I wonder, compared to YYC, how might it be different at USF Health? And we also have someone
That
from
would be
Tampa
probably
County.
is Amy, because Amy has way more experience with doing this and the way they do it in, and I don't. That's why I was thinking about prep and stuff, because I don't really have a whole lot of experience with this. So I don't know, who is Amy still on?
I'm here. Um, yeah, we don't have iPads in the other clinics. So we can't use an iPad or a device. We struggle even with like written screeners that we want to get completed, like PHQ-9s and GAD-7s and things like that. We struggle with consistency
Yeah.
with getting them completed. So, or like, even given to the patients, I should say. And every clinic, we have a lot of different clinic sites at USF, and so every clinic is run a little bit differently. So, I think it's definitely something that we would need to talk about more and like get like the RCO front desk people on board and also like the nurses and everybody on the same page. And it might be like a different flow for each of the sites,
Yeah.
You know what I was
And
thinking?
go ahead, Lisa. Sorry.
I was just thinking what we could do down here at YYC with the residents and stuff that you have come down. I mean, maybe introduce them to the concept of this down here, just to give them a different approach, maybe that they haven't thought about for contraception and stuff, because we have a little bit more time down here. Here everything's a little bit easier to implement and when you've got a half hour, 45 minutes to talk to the patient. So we could look at doing that down here. And I was thinking about, we're trying to look at templating a lot of our visits and stuff and having the documentation built into the visit already, so that then you just have to put in answers or difference to make it easier because anything we can do to make the flow easier and stuff. So that might be something we could look at doing down here.
Yeah, I think that's such a great point. I think the templating, like with starting, getting into the EHR isn't everything, as Amy was saying. Like, so you actually have to, people have to actually do the question and documentation, but having a checkbox, a radio button, whatever it might be, is a kind of nudge and makes it easier to ask the question and easier to document. So I think that that's a great idea. That's having it templated and obvious. But I think, Amy, your point is really good about the next question, which is how can it be implemented in clinical workflow, and then how does that then get sustained, like I said. So things to think about for clinical workflow is what's the current process for rooming patients, vitalizing patients, whatever it might be. How can it be layered on in a way that doesn't ask people in front of the entire waiting room? Who could ask the question, who makes the most sense in a given setting, and then how can that then get communicated to whoever would be providing the care, right? Including potentially making a follow-up visit. And then related to that, I'll just skip onto this because I think that it seems like you're already jumping ahead to thinking about all these things, is how can you make the clinical workflow actually happen, right? As you said. So things to think about with this is how flexible are people in a clinic, and teams in a given setting? How flexible are they at implementing new clinic workflows? Is there an example of, like, we've started doing this new approach to chlamydia screening, and this is the way that worked to kind of build that in a sustainable way in our context, and how can we model it on that, right? How can you ensure fidelity to the question, right? So again, it doesn't have to be exactly word for word, and you want to make sure that people asking the question are aware of why the framing is the way that it is and the potential pitfalls, right? And are there champions? Are there people that you can kind of tap in the medical assistant or health educator space, or whatever it might be, to kind of be someone who feels like this is their thing and really like kind of keeps it moving on the ground? And then can sustainability be built in? How, when you hire new staff, can you make sure that it's something that gets communicated to them in the appropriate way, that it's something that is monitored on an ongoing basis? It's actually something you can query. It's actually an endorsed federal performance measure, whether or not people are being asked SINC at least once a year. So there's ways you could query the database on a quarterly basis and see, are people still being asked that, and use that as a tool to kind of monitor and promote sustainability. So those are things we wanted to think about. I'd love your thoughts on this clinical workflow piece. And I do definitely appreciate the idea of starting it at one site and kind of getting your feet under you, and then thinking about scaling that. I think that's a great idea. I'd love to hear other thoughts you all have about what this could look like.
Okay, I'm going to jump in again here. Okay, so I mean, because we kind of are thinking about down here, this whole overall sort of wellness-based approach to older adolescent, young adult care. And I think this fits in really nicely in sort of everything we're thinking about with mental health, substance use, HIV prevention, contraceptive counseling and stuff. It all fits in really very, very nicely down here. So I think this could easily be a piece that we include in that, as just sort of, again, our approach is, this is part of, overall wellness and health and things that we want to encourage kids to think about when they come here. The hard thing for me in listening to all of this, in particular, like with something like PrEP or something, is to have, kids that don't want to use PrEP, that I know are at really high risk of HIV infection. And, it, in a lot of ways, it was easier when the doctor just told you what to do and you did it. So it's hard, so I understand they're not going to do it unless they want to, but boy, sometimes it's really hard to accept that, okay, you don't want to think about starting PrEP now, but your partner's HIV infected and we know that, and you need to think, so it's just an interesting tightrope to walk in terms of not being telling them this is what you really need to do. And vaccines, vaccines is another one that, when you talk about this sort of, patient choice and different things, is a very difficult topic right now. Because honestly, I don't want to take my grandchild into a pediatric office where people have options about taking or not taking measles vaccine. So it's a difficult, these are complicated issues right now.
Yeah, and I just so appreciate you naming that and lifting it up, that it is cognitively and emotionally challenging to recognize the ways that we are people, right? We have opinions, we have judgments, and to allow that to coexist along the reality that if impacts the care that we provide, then we're actually negatively impacting the patients that we're seeing, right? So I think I hear that. I would say the the um the vaccine example, yeah, I know. I'm not in Florida, just want to acknowledge that. And it is a little bit different in that, for exactly the reason you said, right? That when you're bringing your grandkid into to school with people who haven't been vaccinated against measles, if you have a baby, it impacts, don't have control over the impact it has over the community, right? Whereas when we're counseling someone about HIV prevention and they're at risk, it's impacting them, right? It is the reproductive autonomy piece there. It is their choice and their decisions that impacting their body. So I'm not saying how we should be counseling about vaccines. I'm not going to go there, but I'm just saying that sitting with the complexity of this conversation, also I think there is a difference there between the public health rationale for vaccines that people can't control their risk to being exposed to unvaccinated folks, where when we're talking about people's potential for pregnancy or their potential to become HIV infected, those are personal decisions that impact those people, and those are things that we should not be having an opinion on. Lisa, does that resonate with you?
Yeah, but it's, I mean, the HIV, because again, then, you get HIV infected and then you're not tested and you're spreading HIV to somebody else. So the HIV is a very difficult, very hard. If I know one of my patients is not virally suppressed and is having sex, it's hard not to, the discussions are complicated. The contraception is a little bit easier one to sort of to go with that. But then we see it, like with HIV infected pregnant women that are not virally suppressed and don't want to take their meds, and it's that's a murky area too. So none of this is easy.
Yeah, and that's emotionally yeah. So I think if anything else, the examples you're providing make it clear that in the context of pregnancy prevention, we should not have an opinion, right? Because it really does impact that person themselves, right? And that's really, again, we could go down the pathway of a lot of different ethically complicated areas. I still always think reproductive autonomy and person-centeredness are the pathway, but I think the advantage to thinking about the thornier ones are that it becomes very clear that in reality, whether someone is using contraception or not is not fraught with these same things, and therefore we can put our preconceptions aside when providing counseling. I think that I just want to, Cheryl, thank you for your question. Yeah, explanation of benefits are very complicated. So you don't have Title 10 with sliding fee scale. So you don't. I mean, I think it's very, I'll just say, NIFRA, the National Family Planning and Reproductive Health Association, has some things about evidence, explanations of benefits that you can probably find some resources on to help with that. It depends on the context. Obviously you can click the privacy button for private notes, depending on your EHR context. You can do that for Epic. In terms of explanation of benefits, I'm not entirely sure. I think it depends on the context, but I think NIFRA might have some resources for you. So I know we're almost at time, and then we went deep there. Thank you, Lisa, for talking about those complicated areas. And I think really, I just want to lift up that that is really the work of really continuing to think about these things and processing how we react to them and how it affects our care, and recognizing that it's not simple. So I really appreciate that. Rachel, I'm handing off to you.
Thanks so much. And thank you for the discussion at the end. We will share the recording as well as the paper Christine referenced, and also the template for process mapping. So the different sites can look to their existing processes and then build out a process where they can implement SINC. I'm also including the link for our final poll. If you could please complete this poll, it helps with the reporting from the Reproductive Wellbeing Learning Collaborative. This is our final session. Thank you all for joining and participating in this process. Since I am still a part of the Learning Collaborative, I'll of course be on hand to help if sites are interested in implementing it with some basic advice and guidance. We also will send out the link to the SINC website, which offers more structured information about implementation for folks. And if you have specific questions, please feel free to reach out. We have had clinics want to modify, want to tweak different things. And we have definitely advised on that. So please complete the final poll. I've added the link to the chat. It's 5 quick questions that are mostly true false, so quite easy to complete. And if you have any other questions, we'll stay on for maybe about 3 to 5 minutes after the hour to answer those. If not, thank you all for joining, and we will see you at one of the next Learning Collaborative sessions.